Hello, hello, hello. Good morning, wherever you are around the world. Good afternoon, wherever you are around the world. And good evening, wherever you are around the world. I am coming to you live from San Diego, California, where it is 6 a.m. in the morning. And we have people from around the globe that are here to help you talk about something today. We are going to stay in focus. Yes, that was a pun. We're going to stay in focus today for something very special. We're going to talk about accommodation. And I think that it's going to be something incredibly special that you will just absolutely love. We have an incredible group of people today. And let's get our attention on. And we have, a group of people that it's just hard to beat. I'm going to give you some of the names of the people that we have that just are going to make that you think, oh my gosh, how can all these people to come together? First, I want to say hi to my co-moderator, Linda Culpa from Toronto, Ontario, Canada. See, already we're starting from another country, and tell you about Anna Horwood, who, if you don't know who Anna is, then you don't know about accommodation, because we're talking about somebody who's just incredible and so excited that she's here from the UK. And then we have Dr. Maida, who's joining us as well from the School of Orthoptics, because when I started my whole training in ophthalmology, the first person I met was an orthoptist, and I probably would not be a pediatric ophthalmologist without an orthoptist. So it informs everything that I do. And to have some people here that are just so incredible to teach us, who have been studying this their whole lives, is just really incredible. Louise Allen will be joining us, a doctoral researcher who is also at the School of Allied Health and Professions in Nursing, the Institute of Population Health, where Dr. Maida is from. So this is just a group that, Linda, I would say is pretty amazing. And I think you might agree. I'm going to kick it to you to do the next set of introductions.
All right. Thank you, David. And so I don't think David needs any introduction for us. He's basically our heart and soul of WSPOS. And what I've got the pleasure of introducing as part of this collaboration between the International Orthoptic Association and WSPOS, which we're very excited to be a part of. And we're going to start with Dr. Matthew Pilblad, and he's the Pediatric Ophthalmology and Adult Strabismus Assistant Professor, the Department of Ophthalmology in the University of Pittsburgh in the US of A. And then from India, we have Prananthi Satgunam, who is a scientist from the Bryden Holden Institute of Optometry and Vision Science in the Prasad Eye Institute. And joining her, and a familiar face to us all, is Ramesh Takunaya, who is the director of the Child Sight Institute and Center for Technology and Innovation, also from Prasad Eye Institute. If you just push the slide forward, David. So we're all tucked away in our little houses with our screens, but really the energy comes from the audience. So we really encourage audience participation, even if it is just a shout out from where you are. But specifically, if you have comments and questions for our panelists, we want you to drop them into the YouTube comment section. And we're going to be rolling through those throughout the webinar and have some discussions between the panelists, but also through the comment section. And the next one.
This we'll talk about afterwards. So let me stop right there and just say we're ready in terms of where we are around the world. Singapore has joined us, Austria has joined us, Italy has joined us, Spain, France, Latvia, Belgium, Chile, Brazil, Nigeria, Mexico, Brazil, Argentina, India, China, Kenya, Uganda, Zimbabwe, Romania, Hong Kong. It's going on. The world is here. Let's just make it. And Linda, I want to thank the IOA for their incredible partnership in this, because this is the way the world works, and that partnership means that we are working together in a way that is really special, because it helps our patients. So to the IOA, we say a huge thank you for participating in this. and for as always, for making the MDs involved looking good. Do you want to introduce our first speaker?
Sure. So as you said before, this first speaker needs no introduction. So Dr. Anna Horwood is going to be speaking to us on should we care about the ACA ratio? And this is quite a provocative title for so early in the morning. So I'm going to send it over to you, Anna.
Hello, everybody. Can everybody see me? It should be. Okay. Good. Hello, everybody. Whatever time of day it is, I hope you're into a little bit of theory first thing in the session. I have a little message that says my connection is unstable. So I hope this all works. However, should we care about the ACA ratio? To be honest, I don't care a huge amount about it because I've spent the last 25 years researching the ACA ratio. I'm probably the most relaxed person in the world about the importance of an actual number. So I am very, very poor about people's accommodation in general. I'm really interested in it, but not about it. The ACA ratio is the amount of accommodative convergence in diopters associated with each diopter of accommodation. But association doesn't necessarily mean that accommodation causes the convergence. How did we get here? Well, in the 19th century, somebody noticed that convergence and accommodation co-varied. They put up a lens, it changed the angle. So accommodation must drive convergence, mustn't it? Nobody really thought terribly hard about the fact that it's very hard to change the angle and measure the accommodation that results from changing the angle. And that's the CAC relationship. So that's how much convergence drives your accommodation. And because it's so difficult to measure, and we measure it clinically, everybody ignores it. But it's still there. It doesn't mean that it's not anymore. ACA ratios were testable clinically. You ask them to accommodate, the angle changes. We should be using lens gradient methods if we're measuring it at all, because they're the best we've got and still not perfect. There are near distance comparison methods which tell us a little bit about the change, but they're hugely contaminated by proximal cues, so it doesn't actually tell about accommodative convergence. And after we worked out you could test it, then there were some clear associations that these ratios explain some clinical findings. Surgery seemed to change the ratios. And so these specific clinical scenarios reinforce this general theory that sort of filtered into all the textbooks. But there are some inconvenient truths. Clinical ratios that we test are very rarely reliably repeatable, and they're often surprisingly low. 1-to-1 is quite common. All our stimulus clinical methods are unreliable because you never know how much somebody has actually accommodated. You've given them a lens, but it doesn't mean that they've overcome it. The only true ratios are response ratios, so you've measured the accommodation, and they're much more tricky to measure. Most classic studies were on tiny numbers of very expert observers, so not very naturalistic. Also, we only test it to be abnormal, and then we only take notice of it when it actually is abnormal. So half the time, we're sort of ignoring either testing it or what the number is. And then developmentalists and some physiologists came along, so our group and Rowan Candy's group and other people as well. And we found that the main cue to accommodation is most often disparity, not blur. So that CAC linkage, that convergence driving accommodation, is much more important than the ACA for the majority of people. But even within that, the coupling between accommodation and convergence is often flexible and quite weak. And there are big individual differences. So let me show you what I mean. Basically, I won't explain all of this, but basically the taller the column, the better the response. Red is convergence, blue is accommodation. And all the different categories on the x-axis are the different cues that we use to drive our accommodation and convergence. Anything that's got disparity in the mix of the cues drives very good convergence and pretty good accommodation. If you take disparity away, and particularly if you only give somebody a blur cue, your responses drop like a stone and are barely better than a minimal control condition. So whatever the ACA ratio, accommodative convergence isn't the way that most people drive their near responses. And in fact, we find that most people are incredibly tolerant of blur. Lots of people only accommodate when necessary, whatever their convergence is doing. You think that everybody converges and accommodates nicely in parallel. You ask them to do 3 diopters and they do 3 diopters. This actually is a real person, but it very rarely happens. Most people, so this is mean data, under accommodate by about half a diopter for nearer targets. But within these mean figures, there are all these flaky people who do all sorts of weird things with their accommodation and convergence. So the linkage is flexible, it's often non-linear, and there are large individual differences. And this person seems to be able to converge perfectly without accommodating at all. So this ACA ratio, or the AC relationship, only matters to a few of our patients, and it's a relationship, not a ratio. The people that it matters to are the people who are inflexible with their links between convergence and accommodation. And particularly, it is the accommodative esotropias. The ACA ratio does matter to them, and it appears to matter in distance exotropias too. So if you're measuring it and you've measured your gradient method ratio, a high ACA ratio, it tells you that accommodation is tied up with that large angle change. It also tells you that they care about clear vision a little bit more than most. They care about it enough to accommodate. And it tells you that lenses and accommodation are part of your strabismus management. So it tells you you need not to forget about their accommodation. A high ratio really does matter to convergent success esotropias and some partially accommodative types. And it is said to matter to distance exotropias, and it certainly predicts post-op consecutive esotropias, and it may guide your surgical choices. But I feel, and Mike Brodsky in the States also feels, that it could even be the other way around. It could be that the high CAC ratio is the problem with distance exotropias. So convergence and accommodation are still quite strongly linked, but the drive comes from the convergence. They have to converge to control their exodeviation, and that may be driving extra accommodation. So they're converging with their accommodation, but not by their accommodation. Wanting to do extra accommodation while they're converging might lead them to tend towards pseudomyopia. Minus lens therapy still works, and if it works, it shows you that accommodation and convergence are linked. It could be that accommodation is driving the convergence. So you give them the lens, they think, oh, it's blurred, then I'll converge. But it's quite possible that it's the other way around. They need to converge because they've got a big angle, and that might be driving extra accommodation, but it might give them blurred vision. It may be that your minus lenses just allow them to do some extra convergence without giving them blurred vision, so that you're correcting the extra accommodation that they do. But the risk of that is, because a lot of people don't accommodate very consistently and often not terribly well, you might improve things a bit, but it's going to make it perhaps more variable. And you do need to think in intermittent exos that if you put them straight, you've taken away a lot of they don't need to converge anymore. You might have taken away quite a lot of their accommodation. And so it might turn them into a convergent success, a hypo-accommodation convergent success esotropia. So that's why the results are poorer in these high ACA ratio types. A low ratio doesn't tell you very much, maybe genuinely low, that they're linked, but not very much. You converge, you accommodate, and you don't converge very much. It's more likely that they haven't accommodated when you think they have. You've given them a lens and they haven't bothered to overcome it. So you have to be careful with your technique there, because they may be happy with slightly blurry. If it's genuinely low, the ratio, it tells you that accommodation and convergence are relatively independent. It particularly tells you that glasses won't change the angle much. So whatever you do with the glasses isn't going to do much to the angle. It tells you that surgery won't affect their accommodation either. So should we care about a number? I don't think so, to be honest. I think in my head, I use the effect of what the glasses do and what the full correction does and what lenses do to estimate how much accommodation is associated with the convergence. But I certainly don't worry about a single number. I tend to think high-ish, so that's about 3-to-1-ish. But you couldn't repeat that often the time. But it makes you think, well, perhaps I should think about their glasses as lenses as part of the management. If it's lowish, under 2, accommodation won't make a lot of difference. So I'm quite relaxed about what goes on. So that's my take on things. Thank you.
Oh my gosh, Anna, I have so many questions to ask you about, but we have from online, we had a quick question, which was, can you explain the difference between disparity and blur stimulus? So one is out of focus and the other is the disparity where they're not aligned.
Yeah. A blur stimulus is that you put up a lens, you give them blurred vision, and they work out where something is from how blurred it is. A disparity stimulus is diplopia. So you've given them a prism, you've changed the disparity cues, and because you've changed the disparity cues, like looking at convergence, you work out where it is on the relation of how disparate the image is. So within a target coming near, you've got disparity, you've got to converge, you've got blur, you've got to accommodate, but you've also got looming proximal cues as well. And it's which of those most people use most. And if you look at Worth's components of convergence, he says 2/3 of it is accommodative. We find that it definitely isn't, that a very small proportion of those 3 stimulus is accommodative. Most of it is disparity-based fusional convergence.
So keeping all those in mind, is this trainable? Can we give someone the ability to get better at this with convergence, blur, or disparity exercises, that they learn how to recognize it and train away it and get better at it?
Yeah. That's what orthoptic exercises are, basically. But I don't think that it actually, I think what orthoptic exercises do, so things like stereograms and positive and negative fusional convergence exercises, basically what you're doing is then to teach them to do one without the other. They've got into a muddle with their binocular vision because they can't do one without the other. What orthoptic exercises does is dissociate that a bit. You teach them to converge without accommodating or accommodate without converge. And I think what happens in a lot of convergent success esotropias, if they have bifocals and they've been managed with bifocals, they just learn that they can eventually accommodate without converging too much. And you have to sort of sneak it up on them. So I think that's what orthoptics is.
Oh, wow. We're going to keep talking about this the entire session. You have kicked open the door to a fabulous conversation. You just talked about one way to affect the accommodation convergence in their relationship through orthoptic exercises. Matt, we're surgeons. Well, can surgeons operate and affect that ACA ratio? Can we affect accommodation? This is your chance. Your slides look beautiful.
Perfect. Can you hear me okay?
We hear you loud and clear.
Perfect. So I'm Matt Pilblad. I'm going to talk about, surgical options for high AC to A ratio. So I don't want to talk, that last talk was excellent. I'm going to simplify it for a dumb surgeon like myself in that if it's more than 10 at near versus distance, that's a high AC to A ratio. So I don't want to try to explain any more than that because I'll get it wrong, especially with orthoptists on the panel. They will definitely correct me. So there's many options. One option is non-surgical. So if you give them glasses and it gets them ortho at distance, that's an option. You could also add bifocals. That's debated on whether you should give bifocals or not for the near angle. But let's talk about surgery. So you could recess both medials. That would be the most common approach. Although recessing both medials, you could come up with a bunch of different formulas. One could be, let's just aim for the distance, and they may still need bifocals post-op. One would be you augment it somehow. So you either add a millimeter, you use the near angle, or people have come up with other calculations, including distance width, which would be your best measurement, near without, which would be your worst measurement, and go in the middle, or take an average of something. Some argue you should do prism adaptation to try to get the angle. You could do a Scott procedure. So you do recess resect on the medials would be another option. People talk about slanted recessions. Most of the time, I would think you're going to slant the lower pole, although I think that's also been debated on which pole do you recess more. You could do a Fodden procedure and posterior pulley, which I'll talk more about. Other options maybe less commonly thought of, but you could do recess resect on just one eye, especially maybe if that was an amblyopic eye or plication. You could potentially use the medial angle for near, the lateral for distance, and try to go somewhere in the middle for your tables. And potentially Botox would be another option, which I'm not going to talk about. I think Ramesh will talk a little bit about Botox later. So my usual approach has been to use posterior pulley fixation. And I'm going to show you a video here, but there's also an excellent video by Robert Clark. That's a video article that you could look as well that has a great video on posterior pulley fixations. So I'm just going to present a case and then show you the surgery. It was a 22-month-old that had been in glasses for 4 months for not a whole lot of hyperopia, but was given to see if that improved things at all. There was concern for amblyopia, so there was some patching done. And then on follow-up, the patient had a persistent left esotropia at distance with a larger left esotropia at near. And so this patient I took to surgery. And my plan was to recess both medials with a posterior pulley fixation. So this is the surgery video. So I typically do fornix incisions. So this is me hooking the medial. You could do limbal. Limbal actually might be a little bit better with posterior pulley fixations and that your exposure is just a little bit better. But I tend to do in kids fornix. But you can, use whatever approach you like to do most of the time. So isolating the medial, I think I skipped forward after it's clean. I like to do blunt dissection here, maybe important, especially for if you're doing a posterior pulley. So right there, I'm starting to already see the pulley sleeve, which we'll see a little bit better here. So medial's isolated. This is a Barbie retractor I'm using to kind of elevate. And then I can see superiorly and inferiorly that's that pulley sleeve going around the muscle. You really want to look to see the tissue diving around the muscle. Here's just a small hook trying to grab that edge. I usually like to kind of slide it along the muscle posteriorly and then just hook that. And then I usually use 5-0 Merceline or 6-0 Merceline. Sometimes you can't get the 6-0 and you could use 5-0. But using a 5-0 Merceline to take a good bite of that pulley sleeve. And then you're going to get a bite of the muscle, maybe 20% of the edge of the muscle, and then you'll slide that to tie that together. I think the key is trying to identify the pulley sleeve and the tissue. When you hook it, it's usually pretty robust, especially in a young patient. And you want to see that tissue kind of diving and encircling the muscle. And so you'll just tie that off. And then you'll do the same thing on the other side. Having a good assistant is helpful for this step, especially if you're doing potentially a large recession with a posterior pulley on top of it. That can make it a little trickier as well. And so you're gonna just do on the upper pole and lower pole. This will be permanent stitch. So I do try to trim these on this, try to leave little tails. I know there's been some reports of granulomas and extrusions of these lately, a year or so after the surgery. Same thing, gonna slide down below, try to get that white tissue there, telling me that that's the pulley sleeve. And then you want to get your Merceline, incorporating that tissue. And then again, maybe 20% bite of the edge of the muscle. Your other option would be a Faden. The Faden back here could be a little trickier. So at no point am I needing to touch the sclera. This is all off the globe. And so the chances of complications, I think, are less with this procedure. Another big advantage, I think, is the reoperation. So if you had to go back in on a Faden, there's going to be a lot of scarring down to the sclera. If you had to reverse that, that would be very difficult. You probably can't reverse the pulley, posterior pulley fixation, but at least hopefully wouldn't be as scarred down to the sclera that you might not have to re-up as much. So again, on the upper pole here, sewing that down. And then trimming that. And then I think I have a still here at the end just to kind of show it. So that's the posterior pulley fixation. So this was at the beginning, just trying to show you that sleeve, that tissue you can kind of see is starting to go down below and around the muscle. And then this is me hooking the upper and the lower. Again, that tissue is going to be encircling it. If you just slide your hook back and catch it, that's it's you know, for a strabismus surgeon, you should be able to find the pulleys without much difficulty. And then that's just a photo of the end. This patient did well post-op. I think this patient I've only seen 2 months post-op for now, but patient's doing really well. Continuing him in those mild hyperopic glasses with a little astigmatism for now. And that's my approach to the high ACD ratio surgically.
Great. Thank you, Matt. Oh, and at this time, we've got a lot of questions flying around here for people. So I'm going to put you a little bit on the spot here with what we're doing with these surgeries. So orthoptists kind of tend to be purists, and we get a high ACA ratio, and we like bifocals. And then if you say surgery, we all get a little bit, because they're just going to come back with their ESO at near again because you actually haven't addressed the high accommodation. So when you have your high ACA ratios and you're not differentiating like by a number, do your surgical results change depending on whether those people have quote unquote true high ACA ratios or just a convergent success esotropia? And with that tucked in there, is this age dependent? Because a 4-year-old, do they behave differently than a 19-year-old who's had this deviation?
So good questions. And there, I think, a lot to unpack there. But I guess the last one was the young kid versus the adult or the older kid. So that's definitely a different approach. So a young kid doing well with bifocals, I'm gonna probably not do surgery. I'll just keep them in the bifocals if that's doing well. Versus say the 19-year-old that we've been trying to wean out of bifocals maybe for years and not able to. That would be, you know, a thing that you would probably you could consider addressing. But a kid that's, you know, controlled with glasses and bifocals is probably, in my opinion, not a surgical patient. You just keep them in the glasses and the bifocal. And so I do think there is a difference between the 4-year-old and the 19-year-old for sure, because we hope that that high ACD ratio maybe improves and that we can wean a lot of those kids. We do just wean out of the bifocals with time. So I do think there's a big difference there. And you may be, you know, your approach would be definitely different there. And then, yeah, surgically, you know, I like to tell my orthoptist to tell me all the info, and then I just say this is what I need to do surgically because, you know, it's bigger at near versus distance, so I'll try to fix that surgically. And then afterwards, if there is hypoaccommodation or things, it could be that we don't get rid of the bifocal, but if we get rid of the ET at distance and hopefully they're have some binocularity, then they're improved.
Anna, do you have a thought on what the mechanism would be why surgery might collapse that convergent success esotropia in a true high ACA ratio?
I think there convergent success esotropias they're blur people. They care about the blur and they're willing to sacrifice their binocularity for near for the sake of making it clear. Whereas the rest of the world, they don't care that much. And I think that it's really important that you make a difference between the ones who are absolutely binocular potential for 40 seconds of arc stereopsis versus the ones with a bit of suppression. And so bifocals can work well for those. I think this collapsing the ACA ratio, I think eventually kids do just learn that you don't have to keep it blurred all the time. And maybe what we do with the bifocals is we reinforce the binocularity. You know, we're reinforcing the fact that stereopsis is a good thing to have. And they start to think, actually, stereopsis is it's a more reliable cue. You know, it's much more accurate than getting things crystal clear. And I think eventually they sort of unwind their own high ACA ratio. If you actually test it, it's probably still not far off the same ratio. But what happens is that they learn to be a little bit more relaxed about their accommodation and a little bit more caring about being straight, because being straight is what threads your needle and it's what does that fine motor control that older kids get. And so there's very little you can do to teach people how to do this. And I think what bifocals do is enable them to learn it. I think I've got into trouble trying to teach people to do stuff with their accommodation. What the bifocals do is that they keep them straight while they learn it by themselves. And I just sit back and wait. But the trouble is that some parents and some children aren't prepared to wait. You know, that you're being pushed to operate because the kids don't want to wear bifocals or the parents want you to put their eyes straight. So I think, you know, had good success with bifocals, but it takes years. And if you're giving them to a 4-year-old, it's going to be 10 years sometimes before they get rid of them.
And I think one of the things that you said that was so important is that some kids are okay with blur and some kids are okay with diplopia. And they present completely differently, and it's fascinating. Matt, the question came in online, and it was actually a question I had for you. In that surgery you did, you only were operating on for what looked like would have been to get someone out of bifocals. Who are your ideal candidates for a surgery like that versus do you also sometimes recess the medial and add pulley fixation for someone who has residual esotropia plus a high ACA ratio? And do you take kids to the operating room just to get them out of bifocals?
So for that video, for video purposes, I did one where it was not recessed and then doing the posterior pulley, just because in that hole there, the videos tend not to be as good if you're trying to recess it and then do the posterior pulley. So yes, you can recess and then do the posterior pulley. For video's sake, that video is better than the other ones that I've done that it's more posterior and just more stuff going on. Very rarely would I just do surgery to get a kid out of a bifocal. That would be maybe that 19-year-old that's been in bifocals that we've tried to wean. And so that patient I was describing, they were ET at 25 at distance. So, that's not a kid that has stereopsis. That's a kid that I'm going to operate because there's no stereopsis. So a kid that has excellent stereopsis and in bifocals, the parents are going to have to complain for maybe years before I decide that I'm going to do it for that. That being said, I have done that. So I know I can think of a patient that I knew very well, the family very well, that really pushed me for a while to do it. The teenager wanted to be in contact lenses and they were in sports and they did not like wearing their bifocals all the time. And so that was a patient that I did just the posterior pulley for that. They did well, but I don't like doing that. That's not a common thing. I just like to continue bifocals often.
So for clarity, you did the pulley surgery and then you recessed the medial?
Not for that video, but you usually we do recess first. So you recess and then do the posterior pulley.
Okay. And as we go along, we're going to have to try and figure out what's going on in the brain when we do all of this and how the relationship between accommodation, convergence, disparity, and blur is affected by us cutting muscles. And then how do epi epigenetic phenomenon where, I mean, perhaps things like what the kids are doing in life all day, maybe even looking at their cell phone all day. Jignasa, you want to talk to us now about what happens when somebody's been staring at something up close and the number of hours they spend doing it?
Certainly will. Yes, let me just share my slides. Can you all see that okay?
Yes.
Perfect. Okay, well, thank you very much for inviting me along. And it's been great so far. And I think some of what you said really resonates, particularly with this topic of the impact of smartphone use on accommodation and what we see in our population when we test them with regards to accommodation and convergence. So I'm just going to talk you through some of our results that we did looking at the impact of smartphone use on accommodation and convergence in particular. So what do we know already about the ocular impact of smartphone use? So there are a number of terms that we use to describe those, asthenopic, vague symptoms that patients often present with, which they experience following like near work. But whether that's computer vision syndrome, dry eyes, itching, but the term that I think is most frequently used now is digital eye strain syndrome. And we've seen an increase in this, particularly following COVID, during and then following COVID. You can see there that the prevalence was like 5 to 65% pre-COVID, which then exponentially increased to 80 to 94% during COVID. The literature is not overly conclusive for the sort of cause and effect of digital devices and digital eye strain. And like Anna mentioned before, it's more of an association rather than the causal effect. There are two main studies, recently studies that looked at this and found that binocular and accommodative changes were not primary cause of digital eye strain syndrome. But Maharajan did report reduced accommodative and binocular functions in children aged 7 to 17. So we wanted to look at the impact of smartphone use on a range of ages, specifically all the accommodative functions. So just to sort of give you a little bit of an idea of the use of smartphone use in kids, and I don't know whether you guys have a similar issue as I do with my own children, trying to get them off their smartphone devices. But a U-Switch survey did found that the average screen time among UK adults is now 5 hours per day, in addition to any other screen-related work they might do. So in addition to the computer use that they do. And as mentioned earlier, what we do on our phone is also an issue that will impact on ocular function. So it's quite hard to find out that sort of cause and effect because it's so multifactorial. What we do on our screens, are we watching YouTube videos, or are we reading Twitter or the news? So it's important to sort of have that information as well when you're doing a study looking at that sort of association. So this graph here illustrates a proportion of time the smartphone is used doing each of these activities. And interestingly, 1 in 10 people aged between 16 and 24 spend approximately 7 hours on Instagram. So that's just, I call it doom scrolling with my own children when I'm just watching TikTok videos after one after another. So the aim of our study was to examine the impact of smartphone use on measures of accommodation and convergence. And we had 45 participants aged between 11 and 42, and that was the inclusion criteria, that they had 0.3 log mile better in each eye. What they did have to do was have a screen time diary for 1 calendar week. And we used the modified computer vision syndrome questionnaire to determine the symptoms. And we collected information on the types of apps that they were also using during that week. The clinical examination at the end of the week included a refraction, best corrected visual acuity. We also did a dynamic RET using the NOT method, near point of accommodation, near point of convergence, and accommodative facility. But today I'm just going to present report on the accommodation and convergence measures. So we have 31 females and 14 males, and the average smartphone use was 4 hours and 35 minutes. There was no significant difference in the average minutes of smartphone use or symptoms from that questionnaire across the age categories, which was interesting in itself, as I think we would have hypothesized that the younger demographics may have had an increased increased screen time. Now, in terms of the symptom score, near point of accommodation, amplitude of accommodation, well, this table here illustrates the median and the interquartile ranges for each of the outcomes that we measured during the study. And what the dynamic RET here shows is that there was an accommodative lag. And I think that sort of is the same as what Anna was saying before, is that they don't perhaps need to accommodate as much as we think they do when they're looking at that distance. Most of the values here are within the age-appropriate norms. There was no significant difference across the age groups in terms of the outcomes or correlation between the symptom score and the average minutes of smartphone use. However, there was a positive correlation here between the average minutes and convergence. So as they use the phone more frequently, their convergence regressed somewhat. We did adjust for age in the regression model, and what we did find was that the increased average minutes spent on a smartphone use, interestingly, predicted a higher accommodative facility, which is quite interesting. That maybe when they are fixed on their phones, is that they are occasionally looking up to say, yeah, mum, I am coming off my phone, yeah, and varying that accommodation facility. So that's something that I think we need to look at a little bit more, just to sort of note really that there were a low number of participants in the study, so we've got to, I guess, treat these results with caution and would need to repeat this. So really, just to conclude, we need to do some more work on identifying the symptoms associated with digital device use and validate that modified, because we did modify the computer vision syndrome questionnaire. We did an earlier study doing some cognitive interviews to look at whether the questions that were in that questionnaire were relevant for use with smartphone use, which we'll be publishing soon. We do bigger cohorts to determine the effect on accommodative facility and convergence. And I think dynamic RET is useful to determine that accommodative response, like we were saying, are they under or over accommodating for the point at which they're looking at, and look at the impact of computer use or smartphone use on ocular alignment and fusion. So looking more at that disparity as opposed to the blur, particularly with the increase in acquired acute concomitant esotropia that we're all seeing in our clinics. And that's me done. Thank you very much for listening.
Hey, thank you, Jig, for that. I think there was some surprising results from that study for people. I think it's a hot topic because not a day goes by in clinic that you don't have a parent that's asking you to tell their kid to get off their phone because they're worried about what's going to happen to their eyes. And part of things that we worry about are things like accommodative spasm, although your results aren't really tying into that, which is, again, very interesting. So that's going to bring us to our next speaker, which is Nancy Satkunam, and she's going to talk to us about accommodative spasm and hopefully not scare us about it. Off to you, Sandra.
Thank you so much, Linda. And can you please confirm if my slide is in the slideshow mode?
Yes.
Excellent. Thank you. So I also thank the organizers for giving me the opportunity to participate in this wonderful webinar, specifically Dr. Ramesh K. Punya for roping me in. I'm going to be talking about accommodative spasm. I have no financial disclosure, and I want to acknowledge my colleague, Dr. Shrikant Bharadwaj, with whom we have actually studied about this condition in a greater depth. Before I get started, I just want to sort of clarify the terminology. Should we say accommodative spasm, or should we call it as spasm of near reflex with an accommodative component? So in a major review by Goldstein and Schneekloth, what they were suggesting was spasm of near reflex is a spectrum of anomalies. You could have all the three components of the near triad being involved, or it could be just a single component. And one of the suggestions that was made in this paper is that we stick to the terminology of calling it as spasm of near reflex. And so that's what I will be using for the rest of my talk. This is the quick outline. I will actually very briefly touch upon the historical overview of this condition and spend a little bit time on identifying and hopefully a little more time on the management protocol. So historically, this condition has been there for, from 1800s, but most of our understanding has come out from this paper, which is almost 100 years old, from Prangan, because that recorded the maximum cases with spasm of near reflex with the accommodation component. Now, what happened was we started to see some trends in our clinic which didn't quite match with Prangan's trend. So we started to systematically study this condition, and in the process, we were doing a literature review. We arranged all the studies in the order of number of patients they were seeing, what's the gender ratio, what's the age range, was it just the accommodative component alone involved, or was it all the three triad, was it just the convergence, and then what was the treatment that was given. We found that a lot of literature were mostly case reports and case series. And as I was mentioning earlier, Prangan's actually had the maximum number of patients, 30. They had less males and more females. And most of the treatment was with atropine. In our study, what we found on 45 patients was that the gender ratio were pretty much balanced, and if at all, it was skewed a little bit more towards males. The maximum component was actually the SNRA component, and we found that only 13% of the patients required long-term atropine. So how do we first identify this condition? History is very important. The parent would come and complain that the child is having frequent change of spectacles. They are not comfortable with it. They're having headache, double vision. And when we do the clinical testing, we find that their visual acuity and their objective and subjective refraction does not match. Sometimes we see an esodrift when we are doing the retinoscopy. We see the pupil size to change, and the retinoscopic reflex is going to vacillate. If we attempt a dynamic retinoscopy, we might see a lead of accommodation. And no matter what lenses you try out, usually their visual acuity never improves to 20/20 or 6/6. And then when we do the cycloplegic refraction, we could see that there is a large difference in the hyperopic shift towards the hyperopia or less myopia. And for our study, we went with a very conservative estimate of the difference should be +2 diopter or more to indicate that the patient is actually having a spasm of near reflex. And usually, when you do the cycloplegic acceptance with whatever refractive correction that you're getting, we would find that their visual acuity actually now improves to 20/20 or 6/6. And in some patients, the esodrift may increase with the cycloplegic, or it may not. And this would relate to the ACA relationship that Dr. Howard was mentioning also. So that is how we identify the condition. And now we will spend a bit more time on the management protocol. So the first thing is to confirm that the patient is having spasm of near reflex. And we do that with the cycloplegic refraction, which definitely confirms that there is indeed a spasm. Then we call the patient for the post-cycloplegic visit. In some places, they say it's the PMT visit. So in that visit, after the cycloplegic effect is gone, we check again to see if there is a presence of SNR. And if the spasm is not active, the refraction is more stable, the retinoscopy is not vacillating as much, then what we could do is we can also do a binocular vision evaluation and refract. And if the spectacles are needed, we can give that. The reason why we do binocular vision evaluation is sometimes we find that patients might be having convergence insufficiency. And as a result of that, they're trying to over accommodate, and that might slip them into the spasm of near reflex, specifically the accommodative component. And we also give them some home vision therapy exercises. Usually these are, in case of its convergence efficiency, it is exercises for convergence. We also give them accommodative flippers just to keep their accommodative mechanism more flexible. And then we just call them for a review visit and make sure that they are stable. Now, in case, if there is a spasm of near reflex, then we try out a technique that's called modified optical fogging technique. I won't get into the details of this, but if you're familiar with Borish delayed subjective test, it's quite similar to that. And after that, we again check and see if the retinoscopy reflex is vacillating. Usually with this fogging technique, if they become stable and they are not in the spasm mode, they can actually read 20/20 comfortably. And then whatever spectacle prescription, if needed, we give them and they fall back into this loop. Now, even after this, if the spasm is still going to persist, then we would actually ask for an atropine refraction. They would come back for the atropine refraction and post the atropine effect, which is usually, we call them after 2 weeks. We once again make them go through this loop. And in case if it still persists, then they would be given long-term cycloplegic eye drops as a treatment. So in our study, we found that 29% of the patients with a one-time cycloplegic drop, they could come out of their spasm. And those who did not, when we did the modified optical fogging technique, 35% of them could be relieved from it. And then with the one-time atropine, 22% came out of their spasm, and it was only the 13% who actually required a long-term cycloplegic eye drop, either atropine or homite, which the ophthalmologist prescribes. So this is what we found, and this is just the recap of what we quickly went through in my talk. And I thank you. I hope I'm on time. And in case if you're more interested and want to get in a bit more in-depth sort of insights in this condition, I would also refer you to these two papers from our lab. Thank you.
Wow, that was fabulous. Thank you so much for that. We're doing this gigantic experiment, right? Worldwide, we're having children look at their smartphones. But I'm curious for our orthoptists. Sandy Ingoglia, who was the first orthoptist who taught me, used to say that after you train someone and if they start reading becomes the exercise. They're keeping things single and clear. Is a smartphone a form of exercise? Is the children want the image to be clear? They want it to be single. You have motion on top of just looking at an object. Is it the ultimate form of orthoptic exercise? Nobody wants to take it on, huh?
I was just going to say, David, I think there might be something in that. I think what was interesting was the regression of convergence. So whilst accommodation wasn't affected and there was an improvement in accommodative facility, convergence wasn't so great. So is it that they can tolerate so much of the blur, but then the disparity becomes a bit of an issue because they're overusing that? I think that's perhaps something to look into.
Yeah, I think they get a bit stuck, and then and then they notice the blur, and then it very quickly builds into a vicious cycle because they say, oh, it's a bit blurred, and then somebody keeps asking them about it, and then blur becomes a problem. I think it's much better to let the accommodation take care of itself. And if everybody gets very anxious about it, and I think a lot of it is just taking the psychological pressure off. And I think whatever we do, it enables them to get on with their lives and not think about their accommodation.
So one of the questions from our audience, and we have almost 70 countries now represented that are listening to our discussion today. I think this is revenge of the accommodative system. If we have surgery is the Jedi and the accommodation system, we can't ignore it, right? This is a big deal. But one of the questions that came up is, should we be using bifocals at all? And if we do use bifocals, can we use progressive lenses? Are they an advantage, a disadvantage, and or contact lenses? In other words, if we're going to add plus at near, how should we do it? And do we need to do it?
I think they're tricky to fit. That's the trouble with progressives, because you've got a small zone. And the thing about bifocals is that you have to make the children look through them. So you need the high segment and a wide field for close work. So I think theoretically, yeah, they're great and they look better, but I think they're really tricky to get the kids to use them properly.
Fabulous. Well, Ramesh, the surgeons in the audience are having their brains stressed. They need to figure out how can they intervene. And is there another way to intervene? Can we use chemicals instead of surgery?
Thank you, David. I think when you look at acquired comitant esotropia, one of the things, as already spoken, convergent spasm as well as accommodation spasm. So if you leave the accommodative spasm component, patients with the convergent spasm, is it the reason? Because if you look at this slide, the classification system has broadened over a period of time. You can see at the center, something like convergent spasm has come in the last few years. And there are other things also coming. And when you're looking at it, some of the psychosocial impact also, we need to look into it, because some of the patients, they will have stress-induced and things like that. So I'm going to demystify what is better, whether you inject a toxin or surgery in these patients. Having said that, you have different things like, is it only toxin or surgery, whether 2 muscle or 3 muscle? Or can we still work with the refractive error corrections and probably prisms and maybe orthoptic therapy in a very minute amount of patients? So it's still possible, because the causative agent here are different. I just wanted to show a very quick video, because people have all over the world have different technique. There are multiple technique. There are EMG machines which are available. Sometimes you use a simple technique using a microscope. You hold the muscle. You just look at the ciliary vessels and then inject, stabilize the needle. And as you are injecting, make sure that you are pressing that with the cotton bud, because you don't want this muscle, the toxin, to go into the other muscles or even the lid, so that you don't want a consecutive or a new onset strabismus or a new onset ptosis. So that's one of the things. Let us look at quickly 3 cases. Whenever you get an acquired comitant esotropia, you will definitely do a cycloplegic refraction, give appropriate glasses. You always ask about the screen time, both the reading time, near work, evening time reading with the sleeping position, all that you will do. And this is something debatable. Neuroimaging, we will always do it, even if it is 1 in 1,000. So with all that, 2 months later, she still has this problem. And look at this child, again, a very similar thing, 7-year-old with 4-month history. And she also has a very low hyperop. We cannot ever dismiss this hyperopic power, especially in a accommodative or a comitant esotropia. Again, neuroimaging is normal. What we have done injection of botulinum toxin in the second case. What happened? We didn't want this. Consecutive exotropia happened and maybe the ptosis. But after a few weeks, she became all right and she developed a little bit of exophoria and she's fine. What about the first patient? She directly underwent surgery and she's doing well over a period of time. Case number 3 is a 6-year-old, screen time of 14 hours. Can you look at this? 14 hours for a 6-year-old is a lot. So this is what she is coming. And the old photograph does not show any kind of esotropia. You can look at it 2030, 2025. This is the cycloplegic refraction. Again, gave that glasses. Neuroimaging was normal. She was given 5 international units. 1 month, she was a little bit of esotropic, and it started building up over a period of time. Probably that 14 hours of screen time made the muscle so spasmodic. Probably, we don't know. It did not work in this particular patient. So where it does work, where the toxin works, where the surgery is required. In this particular patient, we had to go for surgery. At the end, she was okay. She regained her Strabismus. But if you look at the studies, all these acquired esotropias are classified, especially in this study. Small angle, they defined as less than 40. Large angle, more than 40. Look at this chart, post-operative 1 month and 3 months and 6 months. What is happening with the surgery in the first line and the botulinum toxin? Definitely surgery worked better in this cohort. As we see both in the small angle and large angle, when the time passed, the esotropia recurred in the botulinum toxin. That was their conclusion. It was not as effective as conventional surgery. What about this study? They had a 2-year-long follow-up comparing surgery versus botulinum toxin. Sure enough, you can see the dotted lines here. That is the surgery and the botulinum toxin over a period of time. What exactly happened? You can see almost 30% of them, the esotropia recurred. But do you think 2 years? Yes, probably it is 30% in this particular. So they also said that it's provided quantitative evidence that augmented dose surgery is better compared to botulinum toxin. However, they were just proposing botulinum toxin could be still an option for small angle deviation. We looked at our group of patients where we did not consider botulinum toxin. We got a success rate of around 73%. And there is one study saying that botulinum toxin gave close to 94% in this particular study. So in summary, what is really happening is the duration of the esotropia, onset to presentation, and onset to intervention. Probably this is as a role in terms of looking at what is better. Probably the angle of deviation, screen exposure and near work. In the previous paper, which is published in BJO, the near work continued. That's why in some of the patients, esotropia recurred. Are we really looking at the stress and the psychological factors as we see in spasm of accommodation patients as well? And stereopsis at onset, and obviously amblyopia always plays a role. So in summary, botulinum toxin could have an operational simplicity, lower cost, reduced trauma. Probably there could be recurrence over a period of time, and transient ptosis and overcorrection can happen, and better outcomes probably in other than comitant esotropia, I think. In summary, probably one message we can take is this may need further discussions and research. Larger deviation, longer duration, probably tilt towards surgery. Lesser deviation and lesser duration, probably botulinum toxin. And always remember, if the increased near work or digital exposure continues, they can have recurrence. Probably it may be fair to say optical correction and orthoptic therapy in 25%. Botulinum toxin probably will work in 50% of the patient, and nothing, including surgery, will have 100% success rate in each and every patient. Thank you very much for your kind attention. Thanks a lot.
And thank you, Ramesh. Wow, that was quite the thought. Your summary slide listing all the factors that we have to think about when we're approaching these cases was fantastic. That's a lot to disentangle, but wow, I see multiple PhDs being able to figure that out. That was wonderful. I have a quick question in our chat space here for the whole panel. It's about whether or not you advise against smartphone use in children that have accommodative esotropia, presumably because you're concerned about triggering either accommodation or convergence after effects for that. Now, I personally don't tell kids with accommodative esotropia not to use their phones, don't differentiate, but how does the people in the panel deal with that? Nobody does, like you don't say, if you have accommodative ET, do not
I just
be on your
say,
phone.
take regular breaks. I tend to be very laid back about and non-judgmental. Just don't do it for too long. And, you know, the parents sit and nod when you say they're doing too much phone. But, you know, if it's a family issue, I'd rather not have more stress in that child's life with its mother telling them not to do stuff all the time. And so I think I sort of just say, don't do it too much. I don't stop them.
Yeah.
But you know, too much is more than 20 minutes. It's not 5 hours, you know.
Yeah. I think it's key to just regularly alter your fixation. So it's like what we used to say for computers when the display screen equipment health and safety guidance came in, is to take regular breaks and alter your focus. And that's what I would recommend. I wouldn't, like Anna said, to say not to use it, but just to moderate it.
My discussion sometimes includes, aspects around the psychological child health of using smartphones, which sometimes comes in, and there's other reasons why they might want to reduce their smartphone use as well as their eyes, which is why it was interesting listening to the last talk. That comes up quite often. And keeping them awake at night as well.
Great. Right. So with that, we're going to move on to our final speaker of the day. This is a little bit of a shift in our mindset. It's a little bit no surgery or clinical things. This is going to be Louise Allen, and she's going to talk to us about accommodation in children that have special educational needs. I'm really looking forward to your talk, Louise. You can share your screen.
Thank you. Can you see that there?
Yes.
Brilliant, thanks. So yeah, slightly different. I'm going to talk about accommodation in children with special educational needs. This is my particular area of interest. I care of children with special educational needs, and by that I mean children that might have more than one area of and maybe a delay in development in that area, so in more than one area. So just to give you a bit of background, here's me. So I'm an orthoptist. I work at the University of Liverpool, but I used to work heavily in clinic before I came into my academic career. And now I'm having fun in my orthoptic clinic, working in a multidisciplinary team. I'll share from experience rather than a lot of the research today. So I'll talk a bit briefly about at-risk groups who might have reduced accommodation. So the aspect about accommodation I'm talking about is having a lack of accommodation or reduced accommodation is what we find in children who have special educational needs. What I'm thinking. I'll also apply it from kind of the whole child. I've got the F words on there because I like to work from a whole child aspect, and that includes thinking when I'm doing my clinics about family, fun, friends, fitness, future, and I learned about that fairly recently. I've always thought in that way, but I really like the F words, and it really helps me think about my treatments. So accommodation is reduced, and we don't argue about this, in children with Down syndrome. Around 75% of children will have reduced accommodation, usually found by dynamic retinoscopy assessment. Around 50% of children with cerebral palsy will have reduced accommodation. And there is some literature to say that some children who are born premature will have reduced accommodation, but it's usually if there is a neurological impairment there. So as a whole, I would consider any child If you work in this area, sometimes it's difficult for parents because there isn't a diagnosis and there's just a delay in development in some areas, and they're seeking some help or help at school. And so I would still consider those children in an at-risk group for having reduced accommodation, just because of this heavy literature on a massive amount of them having reduced accommodation. So they're at risk, and so we need to think about it when they come in to have their eye assessments. What I will say, though, in assessment, there are some confounding factors that we need to consider, again, around the whole child. Children with cerebral palsy might have an issue with drooling, and there's a patch, a hyoscine patch it's called, and that's an anticholinergic drug that's given, and that can have an effect and that can reduce accommodation. In addition, there can be other drugs, and so we can get additive anticholinergic effects that we need to think about. So a really good medical history, and again, that light bulb coming on and thinking we need to assess accommodation here, it might be affected. In my background to preparing the talk, I just had a little look, and I did understand that anti-epileptic drugs, carbamazepine being one of them, has a slightly anticholinergic effect. However, I didn't find any literature to say there's ocular problems being found. Another confounding factor is even though dynamic retinoscopy, usually by the NOT method for this group, the picture on the right, that's taking place there where we move the ret, but we keep the target in the same position and then work out the lag based on the amount in centimetres that the patient you need to move forward to bring it clear. Back to bring it clear. Now, what I'm going to say now, so just excuse me for a drink. Even though it's objective, we can have some issues with our testing and being good at it. So some of the question comes up as when we've tested the accommodation and looked at the response with the retinoscope, and there's been kind of a brief accommodative response, is that unsustained accommodation in this child and they're struggling with it and they may need some therapy, or is it that they can accommodate but we've just lost engagement for some reason on the target? So just the same as when we're doing any other of our assessments, there might be some issues with doing the test, and so we might not be able to get a black and white answer and have to do it again. In addition to that, so those high proportion of children who are going to have reduced accommodation, we need to think about our prescribing of just your distance correction. So if the child is hypermetropic, usually with full binocularity, we would tend to let children go uncorrected for small amounts of accommodation. However, in at-risk groups, we might need to consider correcting these smaller amounts of accommodation, which will be really advantageous to them and their lives. Myopic correction. So when I think about this, I think about a particular child that I met that taught me this, and her accommodation hadn't been assessed and she wasn't tolerant of her myopic prescription. She had cerebral palsy on the, if you were going to scale it on the system, on the severe end of the scale, on the gross motor function classification scale, she was kind of trying to reach up to sort of hook the glasses off her face all of the time, and then after a period of observation, it tended to be when she wanted to do a looking at things up close, and so we were kind of, by correcting the myopia, rendering her blurry as veneer because she couldn't accommodate through the glasses. Giving the ad for the reduced accommodation, the lag that the children have, the extended lag, this can cause a problem. As Anna was saying, it's difficult to fit the bifocal prescription. So usually we have this executive segment that goes right across the middle of the lens in a line, or this very large, I've drawn it on there, D segment at the bottom. But it requires, I say fair, they don't have to be fantastic head and eye movement control, but that needs to be involved in our thought process before we can give the bifocals. And then if this is going to be a problem and bifocals are tricky to use, separate readers are an option. But again, this can be really, really troublesome because, you know, glasses on sometimes and glasses off sometimes, and the general a population not necessarily aware of near and distance glasses, and then the person who is wearing them not able to vocalize that's going to be a problem. Try bifocals always first, because in my experience, if a child can see better through the bifocal, they absolutely use them 100%. You can tell the little tilt of the head, all you need is something interesting to see, and they'll use the bifocal segment. So I do think they're superior to the separate pairs, but if we're having trouble, we might need to move to that. My really love in this area is cerebral visual impairment. So a lot of these children have cerebral visual impairment, and that can mean, particularly again on the severe end of the spectrum, it can mean that their sphere or range of visual attention is limited and their world is up close. And therefore, if their world is close range and they've got reduced accommodation, we're not providing opportunities to see. We're not providing opportunities for vision to develop. So that's why it's so important to think about accommodation and the habilitation of it, so that they can access their visual world. However, it's not always easy and clear cut. If the near ad doesn't work, there is a time to persist and there's a time to be curious. So things can get tricky. We've got head rests, postural supports, different medications that vary vision for different times of the day, and it can get hard for clinicians. And parents will do anything for their children. That if you say you need these glasses, they will try and put them on, and they can be quite painful sometimes if there's a headrest and things involved. So we need to work on it. So if we need to throw that out of the window and we just need to make things easier, we might have to change the visual environment instead. And I'll leave you with work from my colleague, Professor Rachel Pilling, on making it easier. So she uses very short phrases and a framework of see it, find it, use it. So all of our work in trying to habilitate vision will be on, can they see it, can they find it, can they use it? And probably if we can't succeed with bifocals and accommodation is reduced, to bring that into awareness, we might need to use big, bright and bold. We might need to use give me time, and we might need to use bigger for near. So I'll just leave you with that. Thank you very much.
Louise, you have pushed one of my biggest buttons. I think that this is such an important topic. If you want to get me mad, tell me that a child's not worth it. And it's not worth the time and the effort, because these children do take more time, more effort, more thought process, more working with the families, more working with the school to understand how they function, what helps them function, and all of the comments that you made. And I think that we need to have a special webinar just for those children, because yeah, I mean, and all of us here, I can probably think of kids similarly who were ignored or put in a corner, who turned out, and I'm thinking of one person right off the top of my head who had cerebral palsy, and teacher said he was unteachable or unlearnable. He needed glasses, and he's now a lawyer. I've been practicing for a long time, and I've watched kids grow up. So every kid deserves this. And so thank you for highlighting how important all of this is as we go along. We only have a few minutes left, and I wanted to kick it open to a panel discussion of, we have orthoptists, we have surgeons, and we have doctors who are seeing patients in their office. How do we work together with accommodation and convergence? What information can we give each other? What should doctors know? What can orthoptists give? With very practical. When a patient's in the office, what should we be doing? How can we help each other? Ignacia, you want to jump in? How do we help each other?
I think we just have to treat each patient individually, and not everyone is the same, and everything in moderation is my probably take-home message.
So what information would I need that you can tell me that I might not know?
That smartphone use isn't the devil, always, and as much as we might
I want to be practical. I have a patient in my office. You've seen that patient. I need information to make some decisions about what we're going to do. What do I need to know? Can you tell me?
you test their convergence, test their facility. If that's good, go with it. But also don't forget about fusion.
Yeah. I think my take-home message was don't worry about accommodation. I think it's much best left automatic. If it's stopped, all our patients get into trouble because it stopped being automatic. I think if we can, so the accommodative spasms and that particularly, they start thinking about it and then they can't get themselves out. So if we can get it back to being automatic, however we do it, whether it's cycloplegic or just talking to them, I think it's not something people should be thinking about. I think accommodation is best left so nobody has to think about it.
Matt and Ramesh, we have people from 75 countries around the world, doctors and surgeons, who want you to ask the question of the orthop. What do you want to know? What makes a difference in how you plan your surgery, or if you decide to go to surgery that an orthoptist can tell you?
I love the answer that I don't need to care anymore. I don't have to remember all those methods on how to calculate the AC to A ratio. I love
Just
that
a bit.
answer.
Think about it, but don't measure it.
I don't. Yeah, I love that answer. That's what I want to hear. Not have to remember all these methods. And just if it's more than 10 a year, then I address that surgically. I like that.
Yeah. David, I would agree with Jignasa saying that we have to take the call from patient to patient basis, not kind of generalize everyone. Like patient coming with accommodative comitant esotropia, probably I have all the documentation. Probably there is not much of a difference in the near and distance. Stereopsis seems a little bit affected, so I probably will not. But if I have an accommodative esotropia, during the follow-up, something is happening, I've done the atropine refraction because, cycloplegic versus atropine refraction, cycloplegia using cyclopentalate versus atropine is a different discussion altogether. It depends upon the color of the iris and the pigmentation. So around the world, people will have some different opinion on this. So once we do that, still I have trouble in deciding for the surgery. Probably I'll send it. Spasm of near reflex, vacillating reflex, I need some help. Patients with the high AC ratio, specifically, I like Anna's comment about don't worry too much about it, but probably in consecutive esotropias with the intermittent exotropia, sometimes if I can't really figure out, these are the cases I really need a lot of help from our colleagues who dedicate most of their time in looking at facility of accommodation and near distance difference. Doing a PAT, it really takes a lot of time. So I can't, have one really rule for every patient. So I kind of customize it. Thank you.
And Ramesh, Brahman Bateman in the early 1980s showed that if you have high hyperopia and you use an atropine refraction, you can, in 25% of the time, find one diopter or more of a difference. 75% of the time, you don't. But in the high hyperopes, that might make a difference between whether or not we go to the operating room. I'm learning a lot here, Linda. I've learned that fusion is our friend, and that you may not have to measure accommodation, but you ignore accommodation at your own risk.
Yeah.
And so this has been pretty incredible. Any comments that you'd like to jump in with?
Just to say that I think that from Orthoptic's point of view, that we're so good at measuring things like amplitude and static things like NPA, but what we forget about are facility measurements. And I think especially given how we use our eyes now, accommodative facility and versus facility are really important tests to have. I think it gives us a lot of extra information. And I think just listening to what everybody's little tidbits were, that would be something that I would want people to take home for their clinical practices starting on Monday. And having said, I just wanted to thank our panel who have covered an incredible range of topics on accommodative function and dysfunction. And I hope that we've made things a little bit clearer for our audience, and to thank you.
Oh, I like that. That was great. Okay, we have about
You're not the only one that can make puns.
I love it. We have about 3 minutes left. Let's go around and everybody one short takeaway. all right? And it's got to be short and to the point. It doesn't have to be pithy. It doesn't have to be a pun, but we'll go around. Linda, rather, will you take us around each and every panelist, and we'll make it quick.
Okay, we're going to just start with the order that we did our speaking in. So Anna, your last one.
Learn how to do a not dynamic retinoscopy, and I use my smartphone as the target, so that I will often tell them that I'm testing their pupils, not that I'm testing their accommodation. I use a picture and a smartphone, and I tell them that I'm testing their pupils, and they usually accommodate.
That's an excellent tip. Matthew?
So I think pre-op stereopsis is our friend, right? So if at some point they had good binocularity before surgery, your success is going to be way better than if not. So these patients that had the accommodative spasm or broke down, those are the patients you want to operate. They do well.
Great. Dave?
Smartphones. Smartphones aren't all bad. Just remember to alter your focus.
And Penampi, where'd you go?
I think we all live in the post-COVID world, and people have gone very, very digital. So accommodation, in my mind, is still important, and especially doing a dynamic retinoscopy will be helpful for us to determine whether we need to push that hyperopic correction or not.
Ramesh?
Yeah, the fusion and vision are our friends, but never forget the relationship between, there is something called convergence and accommodation. And if you need help, always ask, you'll get it.
And Louise, do you want to summarize?
Summarize this whole thing. I mean, it was excellent. I've learned dynamic ret. Yes, I think it's a really useful skill, and it spans across everything that we've talked about today.
Wow. So this was really just amazing. What I've learned is that we need another 90 minutes, and we have to talk about increasing surgical doses. We have to talk about all sorts of questions that have come up from all the people online. This is fascinating, and it's such core work for what we do every day. I want to again thank each and every member of our panel for all their efforts. For those of you who have been listening and want a participation certificate, please send an email to admin@wspos.org, and you will get a response. If we missed any of your questions, email them to the same address. And afterwards, people don't realize this, but we often will answer those questions directly and post those as part of our webinar as well. So we still want to help. There are more webinars coming. We have a grand round of webinars coming just before Christmas. A date will be announced shortly. If you have ideas for webinars, email us as well. We want to answer the questions that you have, and that's really important to us at WSPOS. Remember, WSPOS membership is free. There are so many benefits of being part of the community of the World Society. You join people from literally around the world. And I stopped listing all the countries that joined us because it would have just taken up too much time. But we have friends from around the world, going from Australia in a big circle, ending up here in California, depending upon the direction you go. And it's really a collegial organization. All we want to do is help each other. And Ramesh just sent me a note talking about, I think, ophthalmologists and orthoptists. So it reminded me to thank the IOA for their participation and their incredible collegiality working together. And the quote that Ramesh sent me was, Dumbledore, the important person, said, "Help will always be given when asked for." And I think ophthalmologists have to remember that to ask for that help. So join us at WSPOS. There's also an international listserv that we've been running since 1995. There are over 1,700 participants. Orthoptists and ophthalmologists are welcome. We're talking about issues every day. In your inbox, you will get emails, and you'll be able to see this and get feedback from people around the world. And of course, our audience, all of you, we thank you for joining us. Linda, thank you so much for your help in putting this whole talk together and making sure that we ran on time. And for the IOA again, what a spectacular group and an important group worldwide for making a difference. Anna, talked about not measuring accommodation, which is incredible for someone who has done so much work. But the value and the information that we've learned from our orthoptic colleagues is unbelievable. And of course, our ultimate host, NTOD International, they have been gracious. They've been with the World Society since the first day, and we can't thank them enough for their support and help in putting these webinars together. Without NTOD, this doesn't happen. So a lot of words from me. I guess I've been given the last word, and I'm gonna repeat it. Fusion is your friend. Ignore accommodation at your own risk, and have a wonderful day, afternoon, or evening, wherever you are around the world. Thank you again to our panel, and take care, everybody. Stay safe, and we hope for peace around the world.
Thank you.